Good evening to all, and good morning to the people who are visiting us for the webinar from the West. I am Radhakrishnan, and this is our fourth year last webinar. That means we had been doing it continuously for the last 4 years. That means successive collaborative teaching, which is going on since 2022. And we are so happy that we are able to do nearly 224 webinars by now. And next week, that means on 24th of this month, we will be having an international webinar. International webinar, well, done by almost all the major stakeholders in ICA on certain recent things. The program, well, I'm sure, will be shown to you all today itself by Sanish. And friends, today's webinar is on Neuraxial blocks. Couple of times we spoke on Neuraxial blocks, but today we're looking at certain special areas which needs real amplification and which has not been done so far. Today it's being done by Dr. Sanish and Dr. Sivakumar and his teammates, Dr. Sivakumar, Dr. Edza, Dr. Greeshma, Dr. Sreelakshmi, and well, they'll be presenting themselves as well as answering if you have any query in the end of the webinar. Dr. Sivakumar is a senior consultant anesthesiology and is the associate head of the Department of Anesthesiology at GD Hospital Trivandrum. He is an erudite speaker, knowledgeable man, a loving personality, and a good speaker. And he'll be speaking on certain aspects, which will be followed by all our colleagues, Edza, Greeshma, and Sreelakshmi. About each one, Dr. Sivakumar will be introducing to you all. Before we start the webinar, I request President Jayashree to have some words, especially on our NDPA starting next week, as well as on our annual. Over to you, Jayashree.
Thank you, Dr. Radhakrishnan. Thanks a lot. And good evening, everybody. Dear faculty who have joined us here today to present the webinar, and all the faculty and the students who are attending the webinar. As Dr. Radhakrishnan has just told, it's a very proud moment that next week, this time, we are celebrating our 4th annual anniversary of the webinars. As we've been doing it for 4 years continuously. It's a proud moment because I don't think anybody has been able to do 4 years of consecutive webinars. Same time, on the same day. So that is definitely creditable. Of course, thanks goes to all the speakers who have actually joined us as faculty during all these webinars. Now, coming to the New Delhi PG Assembly, which Dr. Radhakrishnan just told you, this is a concept that we thought should be here like the New York PG Assembly, in which all the doctors, all the consultants, and all the hospitals of Delhi are getting together and having a unified PG assembly. The thought is that with all the senior doctors of all the medical colleges of Delhi, and not only Delhi, NCR, Ludhiana, Chandigarh, they are with us as well. We are sure and confident that we will do a good show. However, of course, we always keep our fingers crossed. It's starting in 10 days' time. And just for you all to know that the registrations are closed because we have a maximum capacity, which is now all booked. 150 students coming from different parts of the country are coming. So we have to really work hard to ensure that it is a success, because that's very, very important. As regards 5th International and the 15th National Conference of the Indian College of Anesthesiologists. The details of this you can see on our website. It is being held in the KG Hospital, Lucknow. And here, of course, the dates are 21st September onwards. And we are very keen that for this you can apply and join. I'm sure the youngsters and the seniors are going to have a very nice time with the various orations and panel discussions. So with these few words about our college, of course, we have another yearbook that we publish every year, and this we are very proud of. And this year too, we shall be publishing one. So with these few words, I welcome you all and thank you very much. Please go ahead with the webinar. Thanks a lot. Thank you, Dr. Radhakrishnan.
Thank you, President. Thank you for the information. And there's something else which I would like to inform you. You know that we are very deeply connected with the American Society of Anesthesiologists in the organization. And American Society of Anesthesiologists, otherwise we refer as ASA, will be conducting their annual in the month of September. And well, if any of you want to go there as a free registrant, well, we may be able to do. Beyond that, we will not be able to help you in any way. Same way, Society of Ambulatory Anesthesia, otherwise called SAMBA. SAMBA also is having their meeting next month, both in America. Well, both are in American groups. Both conducts well in rotation one of the towns. And SAMBA also is a meeting. If you want, we may be able to arrange free registration for you, but nothing beyond us. Anyway, with these words, I request Dr. Sivakumar Pillai to go ahead with the webinar. Dr. Sivakumar, please. Sivakumar.
Yeah, 1 second. Good evening, everybody. Am I audible?
Yes.
Oh. Today, as Sir has just told, we'll be talking on 4 small topics, but common situations where we have some doubts and confusions about what to do. And the first topic among the 4 topics is ambulatory spinal anesthesia. That is using spinal anesthesia for ambulatory surgeries. That is, you are sending the patient home the same day. So, hello. Okay. So, as the definition goes, ambulatory. 1 second. Okay, ambulatory spinal anesthesia. So the introduction, that is, as I already told, ambulatory surgeries are surgeries that we plan to send the patient soon after the surgery is over or within 23 hours. That is, there is no stay in the hospital. Now, most of the ambulatory surgeries are done under GA because we think that recovery is faster for GA and more predictable, because after the general anesthesia, within few hours, you may be able to send the patient home. Now, why not use ambulatory spinal anesthesia? Especially for procedures which we do below T10, where spinal anesthesia is very effective and it can be used instead of GA, especially because it's very effective and more pain control and many advantages, which I'll come to later. And what about patients with comorbidities like severe COPD, OSA, elderly, poorly controlled diabetic patients who, once you give GA, they have more morbidity and they might have more change in their routine pattern compared to when you are giving a spinal anesthesia where the depth of anesthesia is not that much. Now, also, in addition, we have newly licensed short-acting local anesthetics, which can act for a very short time when given intrathecally. And after that, we can, the patient comes out of the block very fast and they can be sent back the same day. Okay, now why spinal anesthesia? Why I'm talking about spinal anesthesia in ambulatory surgery instead of GA? It is a very safe and alternate to GA for ambulatory surgery. Just like GA, spinal patient also can be sent home the same day. And nowadays, since 2013, we have short-acting intrathecal local anesthetics, which facilitates very speedy recovery, so the patient recovers from the block very fast and they can be safely sent home. And during the COVID pandemic, we have learned a lot about regional anesthesia because it was the rule to avoid aerosol contamination. So, lot of cases, even day cases, where even DNC was done under spinal anesthesia, and patients were sent on the same day and without any complication, with no issues. And another thing is that not like blocks and all, spinal anesthesia is highly predictable. It acts very well, and even for a newcomer, it has good success rate. Failure rates are very less if performed properly. So why not use this safe technique and a highly predictable method of anesthesia in patients, which it can be done under spinal anesthesia. Now, can spinal anesthesia meet the requirement of ambulatory anesthesia? That is, you can see the lady standing and going back home. Can it meet it? Because when you are doing ambulatory surgery, you need to start the surgery fast because you cannot wait for a block to act and things like that. So spinal anesthesia is very rapid in onset. Surgery can start very soon, and it's less stress to the patient also, because the technique of applying spinal and the blocks acts fast, so the patient is not apprehensive, and the surgery also can be started fast. And it offers a very good post-op recovery, so that the early ambulation and patient can be discharged very quickly. And compared to GA, when patient, suppose you are doing an orthopedic low volume surgery in GA, if the patient may have pain when he wakes up immediately after the anesthesia, but in spinal, the onset of pain or the wearing of block is somewhat graded, so the immediate pain is not that severe compared to GA. And compared to GA, nausea, vomiting, and is less. And with the newer agents, even voiding after spinal anesthesia is comparable with that of GA. So spinal anesthesia meets most of the requirement that you want. That is, you want less pain, no post-op nausea, vomiting. Patient should be able to ambulate, and it should be able to void. All this can be given with spinal anesthesia, provided you are using the correct local anesthetic. So which local anesthetic? Ideally, if you are practicing ambulatory spinal anesthesia, you should use newer local anesthetics. That is either prilocaine or 2-chloropropyl. Because previously we had lidocaine, which was short acting, but because of the transient neurological symptom, it's no more use. But the two new agents introduced after 2010 are very short acting and almost satisfy most of the property of lidocaine. Now, is there any advantage why you want to go for a spinal when GA can be done? First of all, is the aerosol generating property is very less. You don't have to generate aerosol in the OT. Now, the theater environment and pollutions are theater and its environment. The pollution due to spinal anesthesia is very less compared to GA. And the cost, especially in a country like India, where we think about cost, the cost for a well-conducted spinal anesthesia is much cheaper than general anesthesia. And morbidity and mortality, there is no increased mortality or morbidity with spinal compared to GA. Most of them, both are almost the same. And the patient can be discharged the same day from the hospital, just like GA with a short-acting agent. There is no need to admit the patient overnight just because you have given the spinal. Once the patient has voided, he can be sent out of the hospital. Now, there is also an added advantage when we are using, because you don't need to unnecessarily manipulate airway, especially when the airway is difficult, especially in such a person with severe OSA. Why do you want to give all these sedatives? And the patient's global satisfaction, that is after the spinal anesthesia, if you ask the patient, how do you feel after this? Would you prefer GA or spinal next time? Most of the patient preferred to take spinal even for repeated surgeries. And the satisfaction index was very high. 90% of the patients were very happy with the technique and the outcome of spinal anesthesia. Then the patient can be given oral intake same day itself, especially when you're not doing when you're doing orthopedic surgery and all. You can easily, you can allow them to take early, and it's safer for if you don't have a very good PACU staff, post anesthesia care unit. It's the work is lighter for them compared to GA. They don't have to be compared to GA, the comfort level for them is very high to monitor a patient after spine. Now, the only problem is you need an ideal local anesthetic to satisfy your requirement when you are doing it under for the ambulatory purpose. That is, the onset should be fast. If the onset is slow, the surgeons will get irritated, patient will get stressed because he is not feeling numb, and the surgery is already going to start. Now, regression also has to be predictable. When you say that after 4 hours, I will make you ambulate, or after 3 hours, then that also should come into place. And then side effects, you should not have major side effects with the local anesthetic you are going to use, because you're going to send this patient the same day. Now, bupivacaine was the only local anesthetic until 2010 because lidocaine was out of use. Later only, the prilocaine and chlorcocaine came, and actually the prilocaine is licensed only in UK. US they are still not using prilocaine 2%. They're using only 2 chloroprocaine, which is the shortest acting currently available. Now, talking about prilocaine, it's a hyperbaric local anesthetic. It's fast onset, and its usual duration is around 90 minutes. So you need to do it only for surgeries which last for 90 minutes. And if you are giving it for lower limb or lower abdominal surgery, that is, you usually have to give a dose of 40 to 60 milligram. That is 4 to 6 ml. And after the procedure, you can easily discharge the patient from the hospital within 4 hours. And for ANF procedures, short-acting ANF procedure, just for sphincterectomy or things like small procedure, hemorrhoid, you just need to give 10 milligram, 1 ml of prilocaine, and the action is immediate. And actually, you can ambulate the patient immediately. Immediately after the patient, there won't be much block in the lower limb, and it will wear off very fast. And there are few contraindications, that is, in sickle cell anemia, it's not used, and it unfortunately it's still not licensed for use in US prilocaine. Now, the second short-acting local anesthetic we have is 2-chloroprocaine. It's a ester type with low protein. The onset is very fast, 3 minutes, but the duration is very short, 60 minutes. So you should use it only for very short procedures, for 40 minutes, because the time of draping, bandage, everything. So the actual procedure time you will get is only 40 minutes, because if you don't use it for short procedure, then you will have to supplement it with GA. And for small foot surgery, just putting a K wire or a tension band wire of patella, it's an ideal thing to use. Just you have to give 4 to 5 ml, and within 1 hour, the block will wear off, and the patient can be sent off. But chlorprocaine is not ideal for giving a saddle block for anorectal surgeries, because it's an isobaric solution, so it won't go deep into the sacral roots to block it properly. For this saddle block, ideally, it's better to use low dose of procaine. And some people, in order to send the patient very fast, they go to very low doses. But doses below 30 milligram is usually ineffective, and don't try to give very low doses to send the patient home. Now, some people, in order to get a good post-op analgesia, they had intrathecal opioid to surgeries. If you're not admitting a patient, it's better to avoid it, because intrathecal opioid by itself produce certain side effects like bladder retention and itching and things like that. So if when the patient goes home, it might be a problem. Then long duration surgeries, you better go for prilocaine rather than giving higher doses of chlorprocaine, because even higher doses of chlorprocaine won't last long. And for surgeries where you need a higher block, like a T10 block, like in epigastric, and in those cases also better to go for prilocaine, because being hyperbaric, you can adjust the level of block, but in chlorprocaine, being isobaric, the block will usually be below T10 and you cannot adjust the level. Now, do we have any advantage? I was saying that GA instead of GA you can use SA, but spinal anesthesia. But is there advantage of spinal anesthesia over GA that you should consider when you are giving anesthesia? First thing is that you can talk to the patient, especially if you are doing plastic surgery and all. You want to communicate with the patient about his requirements. Suppose you are doing a liposuction of the thigh and all, you can communicate better, is this enough, and things like that. Now, regarding the choice, you should give the choice to the patient. Most of the time when you are giving an informed consent, especially those people who don't like to give much spinal anesthesia, they make the patient feel that spinal anesthesia is something very tricky or very it can be more harmful than GA. But when you are if you give a proper informed consent, the choice will be always for spinal anesthesia from the patient's side, because one thing is that the pain scores are very much lower in spinal compared to GA after the procedure, and it has minimal effect on the respiratory physiology. The aspiration is less, nausea is less, confusion is less. Patients with comorbidities also tolerate spinals better than GA, especially those with respiratory comorbidities. So there are situations where you think of only giving spinal anesthesia rather than GA in ambulatory setting, because it has several advantages. Now, when you're using spinal anesthesia in a daycare setting, it's not like routine IP cases. You have to concentrate on certain things that will help in discharging the patient. First is, well, as we know, there should not be any delayed mobilization. That is, the patient should be able to ambulate. And prolonged motor block is one of the causes. So don't mix anything that can increase the motor block with the local anesthetic. And if you are using chlorprocaine or prilocaine, the medium discharge time with chlorprocaine is 3 hours, and the block duration is just 1 hour, and you can even safely discharge the patient within 3 hours. And for prilocaine, a little bit longer, maybe up to 4 hours. So there is no any difficulty regarding mobilization. You can easily tell the patient that you can go home after 4 hours. Now, these are some studies which they have shown that with 2 doses, actually, if you want to, you just give the dose according to the surgery and according to your surgeon. If it's a very slow surgeon, you may have to give a little more, and for higher levels also, you have to give little more. But if for small procedures and short duration, don't give more drugs and make the duration longer. And as you can see, the durations are very comparable, but if you use bupivacaine low dose instead of using this short-acting local anesthetic, you will actually end up in more long duration block. So don't give bupivacaine if you want to send the patient the same day. You just use a shorter acting local anesthetic and in adequate doses, not in excess doses. Now, the medium time, if you compare, after a short GA, the patient may be ambulated within 215 minutes, but it's a little longer for a spinal anesthesia patient. We can expect a little bit delay in ambulation, but it's not that much significant. And discharge time, when they're out of the hospital, both the patient will be almost the same time. The only thing is that the ambulation and voiding will be a little bit delayed in a spinal anesthesia patient, which was not very much significant. Now, before you ambulate a spinal anesthesia patients, check the straight leg test whether the motor has returned, the sensation is there in the leg, and you do the proper reception. Then only mobilize. Your mobilization is important. Don't be very hasty. The patient should not fall and land up. Then the patient will lose confidence and they won't be able to go. So wait for the block to weigh up properly, then only ambulate the patient. Now, the next problem is the post-op urine retention. This is also a problem when you are giving spinal, because they may not able to empty themselves. Then you cannot send them home. So in these situations, this mostly happens if you use fentanyl. So without fentanyl, actually, the studies have shown that none of the patient develop post-op urine retention. And if you're using short acting local anesthetic, they will recover and void before going home. So most of the you can see the voiding time. The short GA also prolongs voiding. Not that GA doesn't prolong voiding, but compared to spinal, it is a little bit earlier. Recovery of blood function is a little bit earlier, but not that significant to keep the patient home. And another thing is that if you are planning, you limit the IV fluid. If you give so much fluid, then voiding will become a problem, because the bladder will be over distended. And if the bladder goes above, urine in the bladder goes about 600 ml, then it will be difficult for the patient to void, and painful also. Then you may end up in catheterization. Then, as I already told, avoid intrathecal opioids unnecessary, especially if you're sending them home the same day, because it may produce delay in voiding and things like that. Then certain risk factors are there. Such patients may void poorly post-op, especially the elderly people and those after urological procedure, especially cystoscopy and all, they may have difficulty in voiding. So such patients, you have to make them void before you send them home. Now, another problem is after anesthesia, both GA and spinal is post-op nausea, vomiting, and it's well known that GA produces post-op nausea, vomiting, but spinal doesn't produce that much unless you add intrathecal opioids, or you give very high block level, or you develop the patient have severe hypertension following spinal. Such situation, unless those situation doesn't arise, post-op nausea is not a very common problem in spinal anesthesia patient. And by using short acting, actually this is very much less, because the unopposed vagal activity will return very fast, and so they won't have this nausea. The peristalsis will be okay, and they won't have much nausea, vomiting. Now, this is one of the good advantage of spinal, especially when you're using in arthroscopies, short duration arthroscopies, or implant removals, or orthopedic procedures. And urological pain will not come immediately, as in the case of GA, when the patient suddenly wakes up, he starts feeling severe pain and things like that. In spinal, the onset of pain, the pain is somewhat delayed, and it will be not quick. It will be sequential lowering. That is, he will start initially feeling little sensation, then a little bit of pain, then only he will go to a severe pain. So you have time to give proper analgesia and help the patient in this situation. Then in post-op, when you're using spinal anesthesia for ambulatory, you have to use multimodal anesthesia. You have to supplement with non-opioid analgesics to make it more the post-op period more comfortable to the patient. And if you want to give regional blocks also, you can do it just like in GA. But pain is better controlled with spinal compared to GA. Now, one common problem which people say or make an excuse for giving when they go home, like when they sit and things, needles, especially the 27 gauge, the needles, the PDPH incidence is very less, and when you, especially in the vulnerable ages, you try to use smaller needles. And there's transient neurological symptoms with this short acting also is very less, and a major neurological complication also after spinal is very less. So you don't have to monitor them after in hospital after spinal anesthesia. So how we will conclude what is the advantage of spinal anesthesia in ambulatory setting. First of all, spinal anesthesia is alternate choice to GA for daycare setting. No doubt about it. It can be considered wherever you feel it's appropriate. It's very safe, cost effective, and actually patient comfort level also is not less. It's all patient satisfaction also is very good. Now, in very severe OSA, a patient with COPD, smokers, you just want to avoid GA, spinal is safer in these patients, and you should be given. And when you're doing, the only thing when you have to consider is when you are giving a spinal anesthesia, use the short-acting drugs where required. Don't use lower doses of long-acting drugs. It won't help. So you practice using chlorprocaine and prilocaine, and you will find that it is very convenient. Even DNC you can do under chlorprocaine and send the patient comfortably, especially if the patient is having severe OSA and all. You can do even short procedures like DNC and send the patient safely without much issues. So thank you everyone for your patient listening. Hello.
Now,
Hello. Yes.
yes, yes. You can introduce the next person and request the person to go ahead with the topic.
The next talker is Dr. Edza Davis. She's a junior consultant in our department. She's going to talk about failed spinal anesthesia, why spinal anesthesia failed, and if at all there's certain ways how you can improve yourself or manage such situations so that the blocks doesn't fail so frequently, and how to manage a situation when you land up in a failed and spinal anesthesia. So it's over to Dr. Edza for the speech on failed spinal anesthesia.
Thank you, sir. Is it visible? Am I audible, sir?
Yes, yes, you are audible.
Yes.
We can see.
Good evening, everyone. Today I will be talking about failed spinal anesthesia and briefly discussing the causes and management for the same. So the question comes, what is failed spinal anesthesia? So a spinal anesthetic which has been attempted, but satisfactory conditions for proceeding with surgery are not obtained. So the failure encompasses a spectrum, and it includes total absence of any neuraxial block or development of a partial block that is of insufficient height, duration, or quality. So both these things are considered to be a failed spinal anesthesia. So we all know Gaston Labat. He is the father of modern regional anesthesia. He, in 1922, had quoted, two conditions are therefore absolutely necessary to produce spinal anesthesia: puncture of dura mater and a subarachnoid injection of an anesthetic agent. So similarly, lack of these two can lead to spinal failure. So here we will be briefly discussing the causes and mechanism of failed spinal anesthesia and then going over the management as to what to do in such a situation. The incidence of failed spinal is very variable. Some institutes, it's only 1%, whereas a teaching institute in America has said that their incidence to be about 17%, and they themselves have said that most of the cases in such was avoidable. There is a lot of inter-institutional variation, but on an average, failed spinal incidence is around 3 to 4%. Now coming to the causes. So the causes can be because of one, we are not able to or impossible to reach the subarachnoid space. That is a problem with the lumbar puncture, or the drug has been injected into the correct space, but the block does not work as expected. Or the drug works, but the dosage that we have chosen is not correct or inadequate. So these can be the three causes for failed spinal. The mechanisms for this can be briefly divided under unsuccessful lumbar puncture, solution injection errors, inadequate intrathecal spread, ineffective drug action, and inadequate subsequent management. So I will be briefly going over these mechanisms. So unsuccessful lumbar puncture, this is the most evident cause of failure here because of an inability to successfully access the subarachnoid space. That is also called as a dry tap. You insert the needle and you do not get a CSF backflow. So this can occur because of incorrect needling techniques, poor patient positioning. This I will be discussing later. Then a lot of anatomical abnormalities, like a patient with kyphosis, scoliosis, patients post lumbar fixation surgeries, morbidly obese patients, elderly patients, patients with calcified laminae. In all these patients, there we can have a lot of difficulty in just getting the lumbar puncture or getting into the subarachnoid space. Another common factor could be equipment-related issues. So there could be a blocked spinal needle, which could be a manufacturing defect. This is quite rare, but most frequently, the spinal needle is blocked because of blood or debris in the needle, which is either because of small manipulations that we do without the stillet. So in such case, it is very important to check the needle before using, and always using the stillet when introducing or manipulating the needle. Now, the importance of position is vast. So optimal positioning is vital to facilitate the needle placement. The patient should be on a firm, level gurney or bed that can be adjusted in height. And the patient should be asked to curl up, flexing the entire spine so as to maximize the space for needle insertion between the spinous process. Now, there always a talk on lateral versus sitting position. Literature says, in literature, there is no definitive, there is nothing like one is better than the other or in terms of failure rates. But it is known that sitting position helps in better identification of the midline, especially in obese patients or patients with scoliosis. You can easily identify the midline if the patient is in sitting position rather than lateral position. So that advantage is there in sitting position. Again, there are studies which have said that the onset of action, spinal, is slightly delayed in sitting rather than lateral position, but the extent and duration, there is no difference in either of the two. Needle insertion technique, we need to have a good knowledge about the spine anatomy for this. The most common site of insertion is along the two-phalanx line, which is the line joining the superior upper border of the iliac crest. Most common is the midline approach, but in conditions where you have calcified ligaments, a paramedian or a lateral approach can also be tried. Again, with the paramedian approach is useful in such situation, but it is technically more challenging. And use of adjuncts. Now, the purpose of adjuncts is to maintain the ideal position, allay patient concern, and minimize movement, thus providing the best possible conditions for lumbar puncture. So this includes pre-procedural counseling and forming a rapport with the patient. This helps in allaying their anxiety during the procedure, spinal procedure, and they'll be more cooperative and understanding for us to perform the procedure. Amount of anxiolytic medication can be given, but care should be taken to avoid over sedation. And always a good local anesthetic infiltration at the site is also very important, but care should be taken that we do not obscure the anatomical landmarks while giving this. And now recent advances, we have ultrasound guided spinal can be given. Although real-time ultrasound is not used for real-time blocks, but under ultrasound guidance, we can mark the midline in morbidly obese patients and difficult spinal, where anticipated difficult spinal cases, we can mark the midline and the point of injection, and it really helps to prevent failed spinal in such cases. Now, there is another condition called pseudo-successful lumbar puncture. Here, you get a flow of clear fluid of non-cerebrospinal origin through the spinal needle, and it can mimic a successful lumbar puncture. So this can occur in certain situations, like an epidural top-ups, like in a laboring patient who has a epidural in situ and a epidural top-up has been given. So if once, this is being converted for CS, when you enter the epidural space, the local anesthetic can come out through the needle, mimicking that of a successful spinal. But after you give the drug, it most commonly will lead to spinal failure. A similar situation can occur in patients who have received lumbar sympathetic block. And another condition is when there is spinal arachnoid cyst or Tarlov cyst. So these also may be present at the site of injection. And when you introduce the needle, the cystic fluid can come out, which can mimic CSF, finally giving rise to failed spinal. Now, once you have breach the subarachnoid, arachnoid matter and enter the spinal space. Now, the errors can occur due to injection of the drug. So this can be because of inadequate dose selection. This seen that lower dose selection, that is of 5 to 10 milligrams, is associated with higher rates of failure and loss of injectate. So again, lower lock type syringes are known to be better to avoid leakage. This is more important when we are using a low dose spinal, because even 1 or 2 drops of the local anesthetic lost can lead to inadequate block. Now, misplaced injection. It's always important to ensure a tight, leak tight connection. So the stabilization of the needle is very important. Most commonly, what we do is to rest the dorsum of our hand along the back of the patient and hold the needle with the thumb and the index finger, and then slowly insert the syringe and give the drug. So this is very important, because while you're attaching the needle or aspirating, there can be a chance that the needle can move in or out, leading to failed spinal. And once the syringe is connected, we have to aspirate to confirm free flow of CSF and only then inject the drug. Some authors also recommend re-aspiration of about 0.5 to 1 ml of the drug after completing the spinal injection, so as to confirm that the needle was to confirm the correct placement of the needle in the subarachnoid space. So in this stabilization of needle malposition is more common with pencil point needles. So as you know, pencil point needle, the tip is blunt and the opening is on the side of the needle. So as you can see in the first picture, here the opening is completely inside the subarachnoid space, and when the drug is given, the drug is completely enters into the subarachnoid space, giving rise to adequate block. But if you see the second diagram, that is B, here sorry. So as in the second position, picture, you can see that the needle has entered the subarachnoid space only partially, and some amount of, so when you aspirate, some amount of CSF will come out, but since it is only partially entered, when you give the drug will get into the subarachnoid. Half the amount of drug is entering into the subarachnoid space, the remaining half is entering into the epidural space, and this can lead to spinal failure. Another common phenomenon that is seen with pencil point needle is the formation of a dural flap. So here again, the needle enters into the subarachnoid space, but when we aspirate, the dura moves backward, thus covering up, obstructing the or blocking the opening of the spinal needle. Here again, when the drug is when you aspirate, some amount of CSF will come out, but when you give the drug is either enters into the epidural space or the subdural space, leading to spinal failure. Now, inadequate intrathecal spread. Now, one is lumbar failure. Failure to puncture the arachnoid membrane. Second is problem with injecting the drug. Third, now you have given the entire volume of injectate is successfully delivered to the intrathecal space. The spread of solution within the CSF can be unpredictable. So this can be because of various anatomical abnormalities, such as like in some patients, there can be fibrous tissue or septa in the subarachnoid space, which can limit the movement or caudal, cephalad spread of the drug, thereby leading to a lower block or an inadequate block. Patients who have undergone intrathecal chemotherapy, they can have adhesions in the spinal space, again affecting our block. So these anatomical abnormalities can be present, which can affect the intrathecal spread of drug. Then CSF volume. There is an inverse relationship between the CSF volume and the spread of drug. It is seen that higher the CSF volume, lesser the intrathecal spread of the drug, and this can be one of the reasons of because of which there is inter-individual variation in the level of block achieved by the same amount of drug. And density of the local anesthetic. Most commonly, we use hyperbaric solutions for spinal anesthesia. This is the normal lumbar lordosis that is seen in all patients. Here, if you see, if the injection is given in between L2 L3 level, because of the lumbar lordosis, most of the drug will go cranially, leading to a higher level of a block or adequate block. But if the block is given at the level of L4, L5, because of the lumbar lordosis, the drug can go backwards caudally and get limited to the lower part of the spine. And this can lead to inadequate level of block and spinal failure. Now, next, you have given the drug, but it is not acting. It could be because of the drug error. So, assuming successful lumbar puncture, adequate drug delivery, and normal anatomy, the final possible cause of an ineffective spinal anesthetic is the failure of drug to exhibit block on the neural tissue. So this can be because of injection of incorrect drugs. So there are various case reports of accidental intrathecal injection of tranexamic acid because of similar looking vials of bupivacaine and tranexamic acid, and injection of which can lead to severe morbidity and mortality in the patient. Similarly, there can be chances of syringe swap. Suppose we are prepared for a combined spinal epidural. We have 3 syringes, one for local, one for spinal, and the other for the epidural test dose, and sometimes that can become confusing. So in such situation, it is preferable to use different size syringes for different, like 2 cc for local, 5 cc for spinal, or 10 cc for epidural, to prevent confusion and to prevent injection of incorrect drug into the spinal. It can be because of physiochemical incompatibilities. Very often we use various adjuvants along with the local anesthetics. Commonly used are midazolam, ketamine, clonidine, dexmedetomidine, opioids. All these drugs can alter the pH and the physiochemical properties of the local anesthetic, and this can reduce its efficacy or potency, thereby leading to inadequate or a failed spinal. And inactive local anesthetic solutions. So it is seen that local anesthetic, certain ester local anesthetics, they are less chemically stable, and over time they may undergo hydrolysis, which can decrease its effectiveness. And so, whereas amide local anesthetics are more stable compared to ester, and such problems don't occur with amide local anesthetics. Then there is another entity called local anesthetic resistance. This is, it can occur due to certain sodium channel mutations genetically, but this is very rare. In our country, one of the most common causes is scorpion bite. Scorpion toxin, which is tetrodotoxin, is known to cause certain sodium channel mutations, which can lead to local anesthetic resistance and either failed or inadequate spinal. There are a lot of literature on this, about a lot of case reports where patients who've had recent or multiple scorpion bites have had failed spinals or reduced effect of spinal anesthesia. Now, next comes failure of subsequent management. Now, the perioperative management of a patient under spinal anesthesia is just as important for its success. The patient may perceive unblocked sensations of movement, pressure, or traction, which are experienced intraoperatively to be painful or uncomfortable experiences. This likelihood is heightened by awareness of the clinical environment and the patient's underlying views, fears, and expectations of the hospital setting, which is potentiated by the stress of undergoing a surgical procedure. Failure to address these psychological aspects of spinal anesthesia can lead to anxiety, distress, and the need to convert an adequate spinal anesthetic to general anesthesia. So this is just a diagram or a table where all the different mechanisms and the causes for failed spinal anesthesia has been mentioned. Now, coming to the next part, that is management of failed spinal. Now, strategy for managing an inadequate spinal anesthetic is dictated by 2 factors. One, the time at which the failure is detected, and next is the nature of the failure. So if 15 minutes have lapsed since the intrathecal injection and the spinal block does not follow a typical onset pattern, which is anticipated, it is highly likely that the anesthetic will be inadequate for surgery and additional anesthetic interventions will be required. So this is a table which shows the clinical presentation, the possible causes of failure, and the suggested management strategies. So suppose we've given the spinal and there is no block. complete or total spinal failure. This could be because of injection not getting into the CSF. It can be because of drug errors or syringe swap or faulty local anesthetic. Here, the suggested management strategy would be you can give a repeat spinal anesthetic or general anesthesia. So repeating the block, this can be done if there is no appreciable block is seen within 15 to 20 minutes. Also, when you're repeating the block, you should take steps to eliminate the proposed cause of previous failure. So it could be due to, suppose the batch of the local anesthetic was faulty, then you change the batch of the drug. You can change the, a more experienced anesthetist can give the spinal a better positioning. So whatever must have caused this failure before that, you have to try to eliminate that before you give the second spinal. And because the second spinal obviously there are certain hazards which are associated with the repeat injection. So the high concentration of the local anesthetic intrathecally can be neurotoxic. Lesions of the cauda equina have been reported following multiple injections via an indwelling or intrathecal catheter. In a patchy or low block, there can be unpredictable, extensive cephalad spread with the potential for cardiovascular instability, respiratory embarrassment, or total spinal anesthesia. And if the block failure has occurred because of anatomical factors, then a repeat injection is unlikely to produce a more favorable result. So now next, if suppose there is an insufficient block height or density, this could be because of insufficient drug delivered, or it could be because the injection site is too low, or because of anatomical abnormalities. In such cases, we can try certain postural maneuvers or give added intravenous analgesia or sedation. So postural maneuvers, most commonly what we usually do is give a head down, slight head down position to so that the hyperbaric drug can move more cranially and improve the block. Along with that, they also say it is better. You can also flex the hip and the knee. This helps to bring down that lumbar lordotic curve and improve the cranial spread of the local anesthetic. So next, if we get a unilateral block, this could be because of patient positioning or certain anatomical abnormalities. Here again, postural maneuvers can be tried, or if the operated limb is what is actually anesthetized, then we can proceed with the surgery, provided the surgeon has been notified about it, and patient can be we can give extra sedation or analgesia can be given for better positioning of the patient. Now, in case of a patchy block can occur because of insufficient drug delivery or anatomical abnormalities. Here again, a repeat injection can be done, but with caution. We can added intravenous analgesia or sedation can be added to it, or we can go ahead with general anesthesia. And the last thing, inadequate duration can be because of insufficient drug delivered, syringe swab, or lengthy procedure. So in such situations also, again, we can supplement with intravenous analgesia or sedation, or general anesthesia can be given. Now, a recourse to general anesthesia must be considered if one or two simple measures have not rectified the matter. It is far better to make the decision sooner rather than later and have to deal with a seriously distressed patient. And in a partially effective spinal anesthetic, any degree of sympathetic nerve block will make hypotension more likely, and more care must be taken while inducing general anesthesia. This is again the algorithm for management of failed spinal. What are the clinical presentation causes and suggested management? Finally, again, post-operative management in these patients is very important. We have to correctly document, which may be useful for next, in case the patient goes for another surgery and for allaying their anxiety, etc. And next, in situations where there are, say, 2 or 3 failed spinals in a together, it could be because of a faulty local anesthetic, and that batch of local anesthetic can be further investigations can be carried out in that. So, yeah, thank you.
Thank you, Dr. Edza, for the presentation regarding now managers. Next, we'll go to the next speaker, which is Dr. Greeshma. She'll be talking about a spinal incision, certain special situations where we are confused whether to give or whether we will worsen the situations by giving spinal anesthesia. And sometimes we'll be concerned about the medical legal aspects of giving spinal anesthesia in certain conditions. Now I'll Dr. Greeshma is a junior consultant in Department of Anesthesia at DG Hospital Trivandrum. She'll be talking on spinal anesthesia in certain special situations. Greeshma, you can start.
Good evening, everyone. Just 1 second, sir. Thanks. Screen sharing on sharing. Good evening, everyone. Thank you, ICA, for this opportunity. So my topic of presentation today is spinal anesthesia in special scenarios. So we all know about the contraindications to spinal anesthesia. There are absolute contraindications and relative contraindications. About absolute contraindication, we don't have much confusions. But regarding relative contraindications, there are so many gray areas because in most of the scenarios, there won't be any proper recommendations or any guidelines for choosing a mode of anesthesia. So today we'll be focusing mainly on sepsis and pre-existing neurological disease because coagulopathy, we do have ASRA and ASRA guidelines regarding neuraxial blocks, and fixed cardiac output states that's a vast topic. So today we will be mainly focusing on sepsis and pre-existing neurological disease. So first of all, about a patient coming with a history of previous spine surgery. It is not considered as a contraindication for neuraxial block, but challenges can occur due to anatomical changes. One is the interference with the spread of local anesthetic.
The slide is now.
Sorry, sir. Sir, am I audible? Is the slide visible? So can I continue, sir? Sir? No? Oh, thank you. So first of all, it's the interference with the spread of local anesthetic because after surgery, they will have so many adhesions and so the spread can be affected, and also the presence of rods and screws, all these can interfere the spread of the local anesthetic. Then definitely there will be difficulty in posturing the patient for neuraxial block. Apart from that, for any neurological condition, we have to thoroughly evaluate, not for this case, but for any pre-existing neurological condition, we have to thoroughly evaluate the patient and has to document the pre-existing neurological deficit. We have to have a detailed conversation with the patient and have to explain all the pros and cons with the patient. And we have to weigh the risk versus benefit and then choose a mode of anesthesia. So here also it is the same. We have to evaluate each cases individually and have to choose a mode of anesthesia. One thing that we can do here is that we can put the needle at a level above or below the surgical scar so that we can minimize these challenges up to a limit. So coming to pre-existing neurological disease, our main concern is that if a patient is having a pre-existing neurological disease and we are going for a neuraxial block, will it causes a further insult to the nerve system? Why? Because there can be surgical and anesthetic causes. Surgical causes are one is the intraoperative stretch and compression of the nerve, or the use of a tourniquet that can cause ischemia to the nerve, and hemorrhage, which can affect the perfusion. While the anesthetic causes can be a mechanical trauma while performing a neuraxial block, vasoconstrictors which can cause ischemia, and definitely the local anesthetic itself can cause toxicity. So these can result in a new or worsening postoperative neurological deficit. Upton and McComas were the first to describe this double crush phenomenon. So let's see in detail what is this double crush phenomenon. The first neuron is a normal neuron with a normal axoplasmic flow. Here we can see there is a minor trauma at a single site. So this minor trauma at a single site will not cause distal denervation, but there is a decreased axoplasmic flow distally. Here we can see there is a minor trauma already at a single site, another minor trauma occurring at a different site. This can lead to distal denervation. This is called a double crush phenomenon. And in this neuron, we can see there is a major trauma occurring at a single site. That itself can lead to denervation. And this is the most common scenario that we will be facing, because here already the neuron is damaged. Some disease is there for the neuron, and already the axoplasmic flow is affected. So a minor trauma, even if it is at a single site, can lead to distal denervation. So this is a concept of double crush phenomenon. So first about the peripheral nerve system disorders. Hereditary peripheral neuropathies, actually they are very rare, especially in our population it is very rare, but some of the examples are the Charcot-Marie-Tooth disease, where there will be motor weakness and wasting of the lower limb muscles that can lead to gait abnormalities and difficulty in walking around. Next is the hereditary neuropathy with liability to pressure palsy. Here even a very small pressure or a very small minor trauma can lead to sensorineural nerve palsies. So since they are very rare, definitely recommendations are not being made on these conditions, but there are some case reports. And about CMD, some case report shows that neuraxial blocks can be done and the recovery is uneventful. Only 2 cases have been reported where there was a delayed recovery, and that was due to the use of high concentration of 0.75% bupivacaine for spinal anesthesia. That is only 2 reported cases where there was a delayed recovery. And for HNPP, only a single case report is available of a 24-year-old parturian undergoing uneventful labor epidural. That is the only case report that is available. So as in for any other neurological disease, here also the concept is that we have to evaluate the patient, have to record, we have to document everything, have to discuss with the patient, and we have to take some steps to minimize the risk factors, like surgical and anesthetic risk factors. We have to minimize. Anesthetic risk factor include using a lower concentration or a dose of local anesthetic. Coming to the acquired peripheral neuropathy, of which the most common is diabetic polyneuropathy. Diabetic polyneuropathy, as we know, it is a distal symmetric sensorimotor polyneuropathy, and usually its prevalence is around 4 to 8% at the time of diagnosis, and it comes up to 50% in a patient with long-standing diabetes. The pathophysiology is not much known, but the proposed mechanisms can be deposition of sorbitol around the neurons, or due to the local tissue ischemia due to microangiopathy, or abnormal tissue repair due to increased glucose content in the blood, and mitochondrial dysfunction. So these are the proposed mechanisms for diabetic polyneuropathy. Although there are several animal data suggesting that neural elements in patients with diabetic polyneuropathy are more sensitive to the effect of local anesthetic, so that they are more prone for toxicity and neurological deficit. But human data are lacking in this about this. So we can conclude that always the diabetic patients are very much prone for neurological deficit following a neuraxial block. That is not there. But the thing is that according to our current understanding, the things that we should do is that we should decrease the concentration and total dose of local anesthetic, and also when we are considering the peripheral nerve blocks, we should use ultrasound guidance, because there is a high chance that intraneural needle placement can occur in these patients due to decreased sensitivity of the nerves. So that also we can use, and we have to eliminate vasopressors in order to prevent ischemic injury to the neurons. So that is about diabetic polyneuropathy. Other common neuropathy is chemotherapy-induced neuropathy. Here also the mechanism is like In chemotherapy-induced neuropathy, the mechanism is that there can be defects to the microtubules. Microtubules may form a major part in the exoplasmic flow. So whenever there is an injury to microtubules, the exoplasmic flow can get affected. Then there can be mitochondrial damage and cytotoxic effect on the DNA. These are the causes for chemotherapy-induced peripheral neuropathy. So for some drugs, especially the platinum compounds and all, the incidence can be around 30 to 40%, and it's a dose limiting side effect for such compounds. Like cisplatin, oxaliplatin, carboplatin, all these can produce pure sensory painful peripheral neuropathy, whereas vincristine, paclitaxel, and suramine can cause mixed sensorimotor motor neuropathy. The concern is that the patient with chemotherapy-induced peripheral neuropathy, they are at increased risk of developing a progressive neuropathic symptom if exposed to an additional neurotoxic agent. And also they will take more time for recovery also than a usual person. So caution should be used while choosing Neuraxial block in these patients. And one more thing is that these patients can have subclinical neuropathy also. That also we have to keep in mind. Next is entrapment neuropathy. This is a very common scenario that we will face in our day-to-day practice. The most common will be upper limb entrapment syndromes like ulnar nerve, that is cubital entrapment, carpal tunnel syndrome about median nerve. In the lower limb, we can have lateral femoral cutaneous nerve entrapment that we usually call the neuralgia parasthetica, and that is at the level of inguinal ligament. Then common peroneal nerve entrapment at the fibular tunnel, and the posterior tibial neuropathy at the tarsal tunnel. So these are the common entrapment neuropathies. One study was done in 2001 where 360 patients were with pre-existing ulnar neuropathy undergoing ulnar nerve transposition was studied. And they found that anesthetic techniques, whether it is general anesthesia or regional anesthesia, did not affect the neurological outcome. So entrapment neuropathies cannot be considered as a contraindication for regional blocks. But the choice of anesthesia will depend on the surgical procedure and whether nerve function will be tested intraoperatively and the extent of damage accompanying the nerve injury. So keeping all this in mind, we have to choose the mode of anesthesia. Next, about the inflammatory neuropathy, of which Guillain-Barré is the most important, most common inflammatory neuropathy that we usually see. It's an acute inflammatory demyelinating polyneuropathy, and regional anesthesia is usually considered as a contraindication. Is usually considered contraindicated in these patients. Why? Because the local anesthetic can interact with the peripheral myelin and can cause additional nerve injury, and also these patients can have autonomic instability and can experience an exaggerated response to neuraxial block. But some recent studies have come, especially the one that is published in the 49th annual meeting of ASRA, where they studied 103 patients for lower limb orthopedic surgery, and 18 of them received general anesthesia, where 85 of them received neuraxial block. And the study concluded that neuraxial and peripheral nerve blocks are safe and do not present different outcomes for patients with the Guillain-Barré diagnosis. So this is a recent study that is available. So like in any other, this is not a guideline, this is just a study. So we have to always get to the conclusion depending on individual cases. Next is the post-surgical inflammatory neuropathy. This is a new entity which has been recently described as an autoimmune or inflammatory process that can cause severe post-operative neurological deficit. The diagnosis is mainly by peripheral nerve biopsy. We have seen neurological symptoms in patients after surgery, mostly maybe because of demyelination and all that we have, especially in this pregnant patient, we have seen such demyelinating disorders. But here the difference is that here there is no demyelination and the radiographic imaging will be negative. The diagnosis is mainly made by peripheral nerve biopsy. It is an idiopathic immune-mediated response to stress, especially like infection, vaccination, or a surgery. It can be focal, multifocal, or a diffuse neurological deficit. And as I said, the radiographic imaging will be usually negative. The risk factors include malignancy, diabetes mellitus, tobacco use, systemic infections, and volatile anesthetic agents are also there. That is also a risk factor, and recent blood transfusion. So About this entity, the most important thing is an early diagnosis and aggressive management. The current recommendation is to use high-dose corticosteroids and intravenous immunoglobulins. Since it's a recent entity, there has been no recommendation regarding the use of Neuraxial block in such patients. About the central nervous system disorders, of which multiple sclerosis is a very common condition, it's actually not considered as an absolute contraindication for regional technique. Especially the safety of epidural anesthesia has been established, and it is said that epidural anesthesia and analgesia is safer than spinal anesthesia because the concentration of the local anesthetic which reaches the white matter of spinal cord is only 1/4. So it is considered more safer. And in multiple sclerosis, we have to keep in mind, even though it's a central nervous system demyelinating disease, peripheral demyelination can also occur in such patients around 5 to 47%. So while performing a peripheral nerve block, this we have to keep in mind. And regarding pregnancy, most of the studies about multiple sclerosis are done in pregnant patients. So what is the importance of pregnancy is that during pregnancy, the cell-mediated immunity is usually suppressed for the survival of the fetus, and the humoral immunity plays a major role. But after delivery, the cell-mediated immunity will rebound. And these patients can often experience a transient worsening of the neurological symptoms that can be falsely attributed to the recent anesthetic technique. There are multiple reports that multiple sclerosis patients relapses after spinal epidural anesthesia was mainly because of the use of high concentration of bupivacaine. They say it is, if it is more than 0.25%, there is some case reports of relapse in such patients. And for most of the patients with multiple sclerosis, epidural and subarachnoid anesthesia is not contraindicated, provided the dose of anesthetics are kept to a minimum. In pregnancy, there are some landmark studies. One is the pregnancy in multiple sclerosis, that is SPRINT study, and the other is the POPARTNER study. These two are large prospective studies that has been recently done. All of them showed a good result of subarachnoid block cesarean section with no signs of multiple sclerosis relapse for 3 to 12 months follow-up. And epidural is obviously considered as a better technique and minimal risk for postpartum multiple sclerosis relapse. Coming to post-polio residual paralysis, polio residual paralysis is considered as a non-progressive neurological condition. So, spinal anesthesia or neuraxial block is not at all contraindication in such cases. The concerns are these patients can have kyphoscoliosis, which make it difficult in we'll find it difficult to position the patient and identifying the intervertebral space. And studies have shown that subarachnoid block failure usually occurs when the corpse angle is more than 50%. And in some such patients, we may have to use USG guidance for identifying the intervertebral space. And the asymmetry in the local anesthetic spread that is also proposed, but clinically it's not very significant. And since they have an orthopedic limb, the risk for fracture is very high. The other concern is that they can have muscle wasting or sarcopenia. So peripheral nerve injuries while positioning is more common because the protective muscle mass is not there in such patients. So these are some of the concerns regarding post-polio residual paralysis. But there is another entity for polio, that is a post-polio syndrome. Here, it is somewhat different from post-polio residual paralysis. It refers to the onset of new neurological symptoms that develop several years after the acute poliomyelitis infection, say some 15 to 30 years after the first infection. Here, the symptoms are mainly fatigue and worsening of the muscle wasting in the affected limb, then muscle and joint pains and respiratory difficulty. So these will be the symptoms. So whenever a patient with a post-polio residual paralysis or history of polio infection is coming to us, we have to always roll out the post-polio syndrome. We have to inquire about these symptoms or signs that the patient is having and have to roll out this condition. It is a lower motor neuron disorder affecting the anterior horn cells of the spinal cord. The sensory deficits are not usually present in these cases. So there is no clear recommendation regarding the safety of a neuraxial block or a peripheral nerve block in these cases. So it is better to avoid neuraxial block if the patient is having a post-polio syndrome. One such study has come from India, that is from Government Medical College, Chandigarh. But what they propose is like regional anesthesia may be safer and more effective option, but further studies are still required. So we can't conclusively say that it can be safely administered in patients with post-polio syndrome. About motor neuron disease like amyotrophic lateral sclerosis or SMA, spinal muscular atrophy, regardless of the anesthetic technique, there is possibility of postoperative respiratory and neurological deterioration in patient with MND. So even if it is general anesthesia or regional anesthesia, the disease is progressive, and in general anesthesia, obviously we can have problems while using opioids and while giving neuromuscular blockers and all. And the spinal anesthesia also, we can't rule out whether the worsening is due to the spinal or due to the disease progression. So there, the decision will depend upon the risk and benefit of both the mode of anesthesia. Coming to spinal stenosis and lumbar disc disease, this is a very common thing that we usually come across. Here, actually, most of the time we will take it a bit lightly because this is a very common condition, and what we usually use is like we'll have a radiological imaging and we'll send the patient for an opinion from an orthopedician or a spine surgeon. And the mechanism of injury can be because of the mechanical trauma or the local anesthetic toxicity or ischemia. Mechanical trauma because of this protruding herniating disc or due to the bone spurs or the bone overgrowth. Anything can cause a mechanical trauma while positioning and performing the neuraxial block. So the recent studies have shown that the incidence of severe anesthesia-related complications may not be as low as previously reported, and spinal stenosis and lumbar disc disease can be a neglected risk factors in most of the patients. So we have to be very cautious while giving neuraxial blocks in these patients. In some other scenarios are like epilepsy. Epilepsy is not at all a contraindication for regional blocks, and if it is controlled under anti-epileptic drugs. The only indication for general anesthesia is when the airway is at risk in a post-ictal state. Otherwise, we can safely give neuraxial block when the epilepsy is controlled. Then in case of spina bifida, an MRI is mandatory in any patient with spina bifida to exclude the presence of a tethered cord. It is acceptable to perform a regional anesthesia at a level not affected by the abnormality if tethered cord is not there. Next is intracranial hemorrhages and raised ICP. Intracranial hemorrhage and raised ICP is always considered as a contraindication for a neuraxial block, especially in case of an epidural block. It can worsen the symptom because of the compression of the dural sac by the drug shifting the CSF back into the intracranial space. So that should not be given. And if it is a very mild head injury without clinical manifestations or and with a normal CT, it is very less likely that the patient can have any major complications. So in such patients, we can consider neuraxial block. Otherwise, if there is radiological evidence of intracranial hemorrhage and clinical manifestations of raised ICP, never give a neuraxial block. And about space occupying lesions, it's better not to go for a neuraxial block. In case of spinal cord injury is not an absolute contraindication for neuraxial blocks. We can give neuraxial blocks, but we have to keep in mind that if it's a high cord injury that is above the level of T5, there is high risk for autonomic distress reflexia. That is, there will be severe vasoconstriction below the lesion and vasodilatation above the lesion. It can cause symptoms like hypertension, bradycardia, headache, and pallor. So epidural anesthesia and general anesthesia with a high dose volatile anesthetics is considered protective in preventing autonomic dysreflexia. So neuraxial block can be safely given in these patients. The only concern is that while performing a neuraxial block in a patient with spinal cord injury having sensory deficit below that trauma, it is difficult in determining the anesthetic level, and also there can be hemodynamic instability. There will be respiratory difficulty, and positioning may sometimes be difficult. So these are the concern with spinal cord injury. In case of benign intracranial hypertension, actually neuraxial anesthesia is not considered as a contraindication if the patient is asymptomatic. If there are signs of raised ICP, then don't go for the intracranial neuraxial anesthesia. And it is contraindicated. It's shunned institute for drainage of CSF because our needle insertion can cause damage to the catheter. Coming to sepsis, neuraxial block should be done with caution because there can be associated hemodynamic instability, coagulopathy, and there is a rare risk of epidural abscess, hematoma, and meningitis. Even though these complications are very rare, most of the clinicians believe that associated to context of severe sepsis, it is not justifiable to go for a neuraxial block. The one recommendation that is available regarding sepsis is from the Department of Anesthesiology, Mayo College Clinics of Medicine, and they recommend serious central neuraxial infections such as arachnoiditis, meningitis, or abscess after spinal or epidural anesthesia is rare. The decision to perform regional anesthesia techniques must be made on an individual basis. And except for extraordinary circumstances, neuraxial block should not be given in a patient with untreated systemic infection. But we can give neuraxial block in patients where the antibiotic therapy has already initiated and the patient is showing some response to therapy like decrease in fever, decrease in counts, CRP. In such case, and there is decreased requirement for this pressors and all. If the patient is showing clinical improvement and he's under adequate antibiotic coverage, we can go for a neuraxial block. But the placement of an indwelling epidural catheter in such patient, it's controversial till now. And available data suggests that the spinal anesthesia may be safely performed in patients who can have a low-grade transient bacteremia after dural puncture. For example, if a patient is coming with urosepsis and we have to do a lithotripsy in such patients, we will usually go for neuraxial block only because anyway the patient will have bacteremia after the procedure, but that is not a contraindication for neuraxial block. And epidural catheter should be removed if there is a presence of local erythema or discharge. And there is no convincing data to suggest that a concomitant infection at a remote site can increase the risk of infection, like if osteomyelitis or a lung abscess, like a remote infection that will not cause any problem with neuraxial blocks. And the main thing is that delay in diagnosis and treatment of a major CNS infection, even if it is for a few hours, can worsen the neurological outcome significantly. So that we always have to keep in mind. So sepsis, these are the things that we should consider. If the patient is under adequate antibiotic coverage and patient is improving, and the bacteremia is decreasing, the CRP counts and everything is improving, fever is coming down, we can go for a neuraxial block. But if it's an untreated sepsis, very high doses pressors and all, then don't go for a neuraxial block. And also we have to consider the other entities like coagulopathy and all. So that's all. Thank you. Thank you so much.
Thank you, Dr. Greeshma, for your nice talk. Next, we will be having Dr. Sreelakshmi. She's a junior consultant in anesthesiology at GG Hospital, and she will be talking of some rare complication, not the common or the complications that we usually know or discuss, but some rare situations where after spinal anesthesia, the complications will put us into problem and why they occur. So it's over to Dr. Sreelakshmi for a talk on rare complications. A few of them only we are discussing, not all. You can start, Sreelakshmi.
Sir. Good evening, all. Slides. Now we will be discussing about some uncommon complications of spinal anesthesia.
Can you share your slide?
Yes, sir. Some uncommon complications following spinal anesthesia. First of all, the neurological complications. Though the incidents are rare, it can be sometimes catastrophic. Coming to paraplegia, the incidence is around 0.1 in 10,000 spinal cases. Mechanism can be multifactorial and is usually difficult to identify. Maybe direct needle trauma because of the unusual anatomy, or the ischemia of the spinal cord. Ischemia is caused by the profound hypotension, mechanical obstruction, the vasculopathy or hemorrhage, which can lead to irreversible anterior cord damage. Usually anterior cord is more susceptible as it is supplied by only a single artery, the artery of Adam Davis. Anterior spinal artery syndrome is characterized by painless loss of motor and sensory function with the sparing of proprioception, which is a function of posterior cord. Next one is the cauda equina syndrome. The frequency is again around 0.1 in 10,000 cases. Can result in permanent neurological deficit. Nerves of the cauda equina is affected. Symptoms include the bilateral sciatic pain, bilateral lower limb weakness, saddle anesthesia, urinary incontinence, and bowel dysfunction. Diagnosis is usually by MRI. Possible mechanism is the lumbosacral roots are more vulnerable due to the direct exposure of large doses of local anesthetic, or the prolonged exposure to local anesthetic if a continuous spinal infusion is being given through a catheter. The increased risk is seen in spinal canal stenosis and with small gauge catheter. Reported more when intrathecal lignocaine was in use. Coming to epidural hematoma, the incidence is 0.06 in 10,000 after spinal anesthesia. The incidence is 10 times more in with the epidural analgesia. Bleeding within the vertebral canal is the epidural hematoma. It can cause the ischemic compression of the spinal cord and lead to permanent neurological deficit. Risk factors include difficult or traumatic needle or catheter insertion, coagulopathy, the patients in which the use of newer and potent anticoagulants, elderly age, and female gender. Symptoms include sharp back and leg pain, persistent motor block, and bowel and bladder dysfunction. Diagnosis is usually by MRI. Treatment, it is a neurosurgical emergency if severe weakness is there and progressive weakness is there. Neurosurgery consultation and rapid decompression is indicated. Delay can lead to permanent impairment. Those with mild symptoms can be managed conservatively and watch for progression of the symptoms. Subdural hygroma, it is the subdural collection of fluid, that is clear xanthochromatic or some blood-tinged fluid. This mechanism is probably due to the reduced CSF volume due to the CSF leak via the dural puncture. More susceptible patients are those with cerebral atrophy or those with VP shunt. They may present as a persistent headache and worsening sensorium. Treatment is usually conservatively managed, dexamethasone, epidural blood patch, and if it is severe, so neurological deficits, and then surgical decompression is indicated. Cranial nerve palsies are also rare complications. Case reports are there on upper cranial nerve palsies, most common being the 6th cranial nerve, probably because of its long intracranial course. Intracranial hypotension caused by the CSF leak results in the caudal shift of the brainstem and traction on the cranial nerve. This can, if abducent nerve palsy is there, they can present as postural headache along with ocular palsy and then diplopia. Usually this is transient and resolved within few weeks to months. It's also a conservative line of management. Treatment is similar to the management of postdural puncture headache, and early initiation of epidural blood patch may benefit. Even the lower cranial nerves are also affected. Some reported cases are there on unilateral vocal fold paralysis, probably due to the traction on cranial nerve 10. Nerve injuries, transient nerve injuries are seen in 0.1%. Permanent nerve injuries are seen in 0.02%. Combined spinal epidural technique more frequently associated with radiculopathy or peripheral neuropathy than the spinal. Usually seen with young, healthy patients, appreciation of paresthesia or sharp radiating pain at the time of needle insertion should be taken seriously, as it may be the alarm for spinal cord nerve injury. Needle should be withdrawn immediately and should either be reinserted or an alternative form of anesthesia should be considered to prevent the neurological deficits. Next is some infectious complications like meningitis. In meningitis is the infection of the subarachnoid space. Due to contamination of equipments or injected solution or a breach in any of the sterile techniques, the infectious organism can reach the meninges. Staphylococcal is the most common organism tracked from skin. After spinal, the most common organisms found is Streptococcus viridans, which is an oral commensal, stressing the need for wearing of a mask and other sterile precautions during the procedure. Meningitis present with fever, headache, neck stiffness, and other neurological symptoms. Diagnosis is by lumbar puncture and CSF fluid analysis. It is prevented by following strict sterile techniques. Treatment include broad-spectrum antibiotics, steroids, and supportive treatment. Arachnoiditis is the inflammatory reaction of meninges. True incidence is unknown. A contributory effect of the chlorhexidine disinfection has also been told. Therefore, chlorhexidine should be dried before the needle puncture and avoid splashing of solution onto needle or syringes. Contamination of the injected drugs can also lead to meningitis and arachnoiditis. So these were the neurological complications. Most of the neurological complications present similar like a PDPH. We should not misdiagnose it like PDPH. Though these complications are rare, a delay in diagnosis can be catastrophic for the patient. Next, coming to the respiratory depression. Seen if Neuraxial opioids are used along with the local anesthetic. The risk is dose dependent. Increased risk is seen in those with sleep apnea, elderly, and with co-administration of the systemic sedatives. For lipophilic opioids like fentanyl and sulfentanyl, respiratory depression occurs usually between 30 minutes and 2 hours. But with morphine, that can present like up to 24 hours. 3% risk is there for 0.8 milligram intrathecal morphine. We should therefore watch for respiratory depression, respiratory rate in the patients if intrathecal morphine is given for up to 24 hours. High neural blockade is the exaggerated dermatomal spread of the neural block affecting the spinal nerves above the T4 level. The causes and risk factors include administration of an excessive dose or unusual spread or sensitivity of local anesthetic as seen in pregnancy, or anatomical or pathological abnormalities in spine, or some cases with increased intra-abdominal pressure. This can also the patient positioning, pre-existing epidural block, unrecognized dural puncture, and intrathecal injection of the drug. Symptoms include, depending upon the level of block, hypotension and bradycardia, numbness of weakness of upper extremities and shortness of breath, and shoulder weakness, hypoventilation, or desaturation respiratory arrest occurs when diaphragm is affected, slurred speech, sedation, and loss of consciousness when the level ascends up to brainstem level. Treatment is early identification of the symptoms and sign is the key. Maintaining the adequate airway and ventilation, supporting the circulation. If respiratory insufficiency is there, we oxygenation, assisted ventilation, and if necessary, intubation and mechanical ventilation. Hypotension corrected by rapid IV fluids, head-on position, and IV vasopressors. Bradycardia corrected by atropine, ephedrine, or adrenaline. In case of loss of consciousness, secure the airway. Cardiac arrest is also a rare complication of spinal anesthesia, which incidence varies from 0.04 to 2.5 per 10,000 cases. Exact etiology of cardiac arrest is not understood, and it is more reported in spinal anesthesia. Increased vagal tone and decreased preload are the causative factors. Hypoxemia and oversedation can trigger bradycardia and asystole. Vigilant monitoring and prompt correction of precipitating factors and bradycardia is necessary to prevent cardiac arrest. So these are some of the uncommon complications following spinal anesthesia. Thank you.
Thank you, Dr. Sreelakshmi, for the talk. Now we'll be waiting for questions. Anyone want to ask any questions regarding the fourth topic? They're free to ask now.
Hello, there are some questions in the chat box.
Yes, I've seen some. One
Yeah.
is, does adding fentanyl to spinal bupivacaine affect its efficacy? No, it doesn't affect its efficacy. Actually, fentanyl gives a better block. It speeds the onset of the block, and even it prolongs also the block. So by blocking the other receptors also, the opioid receptors in the spinal cord, so it doesn't affect its the efficacy of bupivacaine. It just potentiates it. Now, another question is how many times we can repeat the spinal anesthesia. That depends on different things. First is why you want to repeat it, why you are failing repeatedly. So without correcting that, there is no point in repeating and doing the same thing again and again. And sometimes you may even have to change the person who is giving the spinal anesthesia. The drugs may have to be changed, the batch of the drugs. So without considering all those things, just repeating the technique won't help. So you have to be very vigilant. After the second spinal, if you fails, then there's something wrong with the technique or the drug or something else. So you don't repeat it third time without sorting out the cause. Find the cause why the drug failed. Now, another question is about
now, regarding that,
yeah.
repeat number of attempts. Well, first day you failed, second day you are doing once again, and second time also you are failing. Will you be looking for a third time? Or
no, by the same person, I don't think it's right to do it.
Yeah.
It shouldn't be done by the same. If at all it's going to be done, it should be done by a different person, not by the same person. Repeating spinal without knowing what is happening. Suppose you are injecting the nerve into the nerves or something like that, could be more damaging. You shouldn't any technique. You shouldn't repeat it if you are failing repeatedly.
That's why
Maybe by another person or another day, maybe not on the same day. I don't think it's advisable to do it.
Another day on another patient. Well, what I am asking is simple. Second time, if you failed and you are not able to identify the cause, it is
then
better,
you shouldn't repeat it.
Better you quit and you give it to somebody else to do it. If at all you want to do a spinal, and 3 times will be the maximum allowed now everywhere. Because beyond 3 times, nobody goes for it. Like the intubation technique also, 3 times is a maximum allowed. Because beyond that, well, it sounds bad and legally challengeable too.
One more question is there. If there is blood in the hub, following which we get CSF, can we inject drug intrathecally? That depends on the type of blood staining you have. A bit of tinge is common because the nerve passes through the vascular space. So a little or some amount of blood already in the tip from the skin may cause a tinge in the CSF. But frank blood, you shouldn't give the drug synthetically. And blood staining can change the action of drug, because sometimes the pH of the blood may change the pH of the drug also. So if you have aspirated blood and if you have repeated and you got a clear CSF, don't give the drug which is already blood tinged. Better load a new drug and give, because sometimes if you give it, it can fail, and again blood is irritant, so it can cause headache and problems when mixed with CSF. So frank blood already in your syringe, don't mixing with the local anesthetic, don't give it. Don't give the same drug. Load a new drug, and that's what I would advise. A little bit of tinge is very common. That's mostly because of blood already in the tip of the needle from the skin prick. That is not a problem. But frank blood in the CSF, don't in the local anesthetic, don't inject it intrathecally. Load a new drug. There's one more question, is that if there is hypotension in a subarachnoid, should we head down or should we raise both legs? If it's immediate, don't do a head down position, because it will lead to the spread of the local anesthetic cranially. So you raise the leg. But if it's after 10 or 15 minutes, you are having a hypotension, you can give a little bit of head down positioning, because it will improve your venous return. So it depends on when the hypotension develops. And hypotension can be managed with vasoconstrictors. No need to do posturing or things like that, because we have given it for a purpose. If you give it, put it head down, this drug will spread to the upper dermatomes, and you may have a weak block down. So better give a pressor. But if you feel it's intractable, you raise the legs. Don't give a head down tilt immediately after a spinal, because because the drug has not fixed. It will take 7 to 10 minutes for the drug to fix completely. I think there's no more question in the chat box.
Thank you. Thank you. Dr. Saloni, you like to say something?
Yes, sir, you can. No,
Saloni,
sir. Yes, sir, you can continue with the vote of thanks, sir.
what a thanks. You don't want to add anything.
No, sir.
Okay. Dr. Sanish, are you there?
Sorry for the interruption, cause sir. We have received few more comments or queries from our delegates, which I have just posted.
Yeah, please post.
Yes, sir.
Sivakumar.
Yeah, a spinal dosage of morphine. Usually if you place a spinal dose of morphine into epidural, it won't produce much harm. But if it is the other way around, it's going to produce harm, because spinal dose of morphine is a very low dose, 100 to 300 microgram. If you place it epidurally, the only thing is that you won't get the desired effect, because epidural you need a higher dose. But if you put a higher epidural dose into the subarachnoid space, say you are going to give 2 milligram of morphine into the spinal space, then you are in trouble, because it will produce delayed respiratory or immediate respiratory depression. One question is regarding morbidly obese patient. Expecting length of needle is not sufficient. Then if the length is not sufficient, you do an ultrasound scan and check the length. And if sometimes there may be areas maybe where you can reach, because the length using the ultrasound, when you measure it, it may be less. You can try at that space. But if it doesn't reach, then there is no way. You cannot do a lumbar puncture with a shorter needle, because you have to have a long needle for a morbid obese patient. Then one more question is settling time of bupivacaine heavy. Actually, the drug can spread up to 7 to 10 minutes. So don't think that after 5 minutes it's safe to change the posture of the patient. But beyond that, it's very rare because we know that other factors like the protein and all those affect the spread of free drug. So maybe after 7 to 10 minutes, then it's safe. You can conclude that the drug is fixed at that position. Now, does preloading or co-loading needed during LS? Both are not needed. The only thing is that your patient should not be dehydrated. You should not be giving spinal in a hypovolemic patient. You correct the volume status only. If at all you start an IV fluid before giving the puncture, and no need to overload or preload or co-load. If the patient is normovolemic, then if at all they develop hypotension, just give pressors. You give either ephedrine or phenylephrine or mefendramin. That's all is required. No need to rush in so much fluid into it. Then another question is safety on injecting wrong drug intrathecally. That's a very catastrophic situation if you reach. Most commonly, it's the tranexamic acid that's wrongly given, because both these are available in the labor room, and mostly it happens there, either in the labor room or the orthopedic section. So you have to be very careful, see that the drug is checked by every month, the technician, the nurses who are going to bring the drug to you, and before injecting also make them read the name of the label loudly, and you also try to read it loudly, so that everyone, if at all there's a mistake, it's identified in time, because a wrong injection can produce a very catastrophic effect, and it's not pardonable, because some of them are really going to damage the patient. So you should have a system by which this doesn't happen. That's more important, because the spinal drugs should be in a separate tray. It should be in a separate section. It should be read by the technician. Everybody should be careful and try to avoid contaminating the drug. That is, this can happen when you pour the chlorohexidine or things into the tray. You should not either you have a separate tray to wipe the patient, or you don't allow them to pour the local anesthetic directly into the tray. You keep the bowl out, or the cotton, whatever you have, and see that the tray is not spilled with this local anesthetic, because chlorhexidine can be contaminating. And don't try to use multiple antiseptics. We see that people wipe with chlorhexidine and betadine and multiple. That's not required actually. In a clean patient, you don't need to use multiple antiseptic. You just need to use one antiseptic. Just give sufficient time for it to act. That's what's required. If you are using multiple antiseptic or things like that, what is you are giving multiple exposures, multiple risk factors for the patient unnecessary. So don't do such practices. Use a single antiseptic. Use it wisely, and don't contaminate your tray. The most that's what I used to tell my juniors and my residents. The most important thing in spinal anesthesia is asepsis and the correct drug, injecting the correct drug. Don't, even if the spinal fails, not the only thing is that it fails, but it won't harm the patient. But if you inject the wrong drug, you're going to harm the patient. And if you do the procedure aseptically without considering the proper sepsis, you are going to produce harm. So these are the two situations you have to practice, and you have to have a good system in place in your hospital, so that these things don't happen. People don't take lumbar puncture lightly. That it should be there. That should be the practice. Then you won't land up in problems. Any more questions?
Chat box, please.
Chat box is empty now.
No, sir. Thank you. We haven't received any further questions so far, sir.
Thank you. Thank you, Nivarna.
Thank you so much, sir.
Thank you, Sivakumar and team members, for the excellent webinar. Everybody spoke very well, and they were absolutely clear in their statements and presentations. On behalf of Indian College of Anesthesiologists, I thank each one of you and look forward to have your presence again and again in our webinars. Thank you all very much. Good night. And we sign off. Thank you.
Thank you so much, dear doctors, for sharing your valuable insights. And we are really grateful for extending us the opportunity to host the session today. Really looking forward to host you again very soon in another interactive session in the near future. Till then, stay safe and healthy and have a nice day. Good night to all. So with all your permission, we are calling the day today. Thank you. Goodbye.